Good morning, everyone. I'll be presenting a topic: role of neoadjuvant immunotherapy in resectable lung cancer, based on the various literatures. Starting with the introduction, the lung cancer is still defined as still considered as the leading cause of cancer-related deaths in the U.S. and the 2024 estimates alone is 234,000 new cases and 125,000 deaths in the US only. And the non-small cell lung cancer accounts for 85% of the lung cancer, while other counterpart, that is small cell, accounts for 10 to 15%. And 25 to 30% of the non-small cell lung cancer are deemed to be resectable. Since the small cell lung cancer has not shown any benefit from the immune checkpoint inhibitor, and they do not have any actionable driver mutation, most of the studies are based on the non-small cell lung cancer. And the 5-year survival in these cases have been shown to be more than 90% in resected stage 1A and less than 40% in the resected stage 3A, which has a direct impact on, as the stage goes up, the prognosis goes down, and the recurrence after surgery is up to 50% in stage 3A, which indicates there is definite need of the effective perioperative systemic therapy. So there are certain limitations of the classical neoadjuvant chemotherapy that we have been commonly using. The traditional neoadjuvant chemotherapy has the modest benefit, that is around only 4% median pathological complete rate, ranging from 0 to 16%. And it also improves the 5-year overall survival by only 5%. Hence, there is a limited impact on the long-term survival by the chemotherapy only. And so if we, so theoretically, the addition of the immunotherapy to the chemotherapy should have definite advantage to the patient, and the rationale for it we'll discuss on later slide. But before that, we have to know about two major things, that is pathological complete response, which is 0% viable tumor post-therapy, and another is a major pathological response, that is MPR, which indicates less than 10% viable tumor cell. And these two have a strong correlation with the recurrence-free and overall survival. So starting with the rationale for neoadjuvant immunotherapy, the first rationale theoretically seems to be early eradication of micrometastatic disease with addition of the immunotherapy, and the preserved tumor antigen exposure as the patient are in optimal health before starting any sort of treatment. The starting of the immunotherapy and then chemotherapy seems to enhance the priming and activation of the cytotoxic T cells. And then chemoimmunotherapy synergy is also another topic on rise, that is chemotherapy causes immunogenic tumor cell death, which releases the neoantigens and danger signals, enhancing the immune recognition. And there is also reduced tumor-induced immunosuppressions. The tumor, they usually try to suppress the native immune cells via the myeloid cell-derived suppressor cells, and these are reduced by immunotherapy. There is also potential to improve surgical outcome by tumor shrinkage, which may facilitate the RJ resection, reduce neural burden and downstaging, and it also allows the assessment of the treatment response. So here in this slide, I have tried to present the comparison of 8th and proposed 9th edition of TNM staging for non-small cell lung cancer. The description of each and everything is not needed, as we have been discussing this for a long time now, but the changes is made in N2 disease, that is N2A and N2B is differentiated, and it is a clinically relevant differentiation in 9th edition, as the study has shown that N2A has better prognosis than N2B, and N2A patient is deemed to be resectable if the involved tumors are not bulky, whereas N2B are taken for the definitive chemoradiation. And also the changes have been made in M1C, which is further divided into M1CA and C2, CB, which is not needed for us. And the 9th edition, there is slight upstaging and downstaging of the stages as well, such as T1 N1 disease is now stage 2A, which was earlier stage 2B. And another definition that we have to learn is defining resectability. So the resectable disease spectrum includes the stage 1, 2 and selected case of the stage 3. And the treatment focus in stage 1A1 and 1A2, it focuses mainly on reducing the long volume resection and minimizing the morbidity. And there is definite need for multimodal approach in stage 1B2, 3A, 3B, especially in the higher stages. There is high risk of recurrence, which demands the combined treatment. And stage 3, the definition is highly heterogeneous and individualized. And the resectability depends upon the tumor factors, if it is peripheral or central, lymph node involvement, patient fitness, and local surgical expertise. ASCO guidelines also includes the key criteria for induction therapy plus surgery in the cases where we can achieve the RGD resection, that the immunotherapy should be added if it is technically resectable, if there is no N3 involvement, and if the patient is medically fit, meaning the expected perioperative mortality is lower than 5%. So before the immunotherapy era, the previous standard of care for the stage 2 to stage 3A non-small cell lung cancer was platinum-based chemotherapy, and the key evidence was provided by IALT trial, which showed 4.1% absolute overall survival benefit, and then the LACE meta-analysis, which confirmed the benefit of 5.4% in 5 years, which is very modest. And the CalGB 9633 trial also helped in refining the patient population, that is, the survival benefit only for the stage 1B patient with tumor more than 4 centimeter in neoadjuvant setting, if we talk about the neoadjuvant setting. So there was always a discussion between neoadjuvant chemotherapy versus adjuvant chemotherapy, and the NATS trials said there was no significant difference in 5-year overall survival. But theoretically, neoadjuvant therapy offers a practical advantage in ensuring completion of the treatment, and it may also help in marginally help in achieving the pathological complete response. But in stage 2A, the use of neoadjuvant chemotherapy alone was still questionable, but the addition of chemoimmunotherapy has shown to be markedly beneficial. So key clinical trials supporting chemoimmunotherapy are LCMC3 trial for atezolizumab, which showed the pathological complete response up to 7% and major pathological response up to 20%, which is far more than the chemo alone and statistically significant. And then another was NADIM-1 and NADIM-2 trial for nivolumab plus chemo, which obtained the PCR up to 36% with improved overall survival. Then CheckMate 816 with PCR achieved up to 24% versus 2% in chemo alone. Then Keynote 671 trial, which assessed the pembrolizumab plus chemo with significantly improved overall survival. And then AEGEAN trial for the durvalumab, which the results are PCR obtained in up to 17% cases. So if we talk about each of these trials in a detail, the CheckMate 816 trial is a phase 3 trial in resectable stage 1B and 3A. The 60% of them had stage 3. And the experimental arm is 3 cycles of nivolumab plus platinum doublet chemotherapy and then surgery with no addition of the adjuvant immunotherapy. And the control arm showed the chemotherapy followed by surgery alone. So the primary outcome was median event-free survival was 36 months versus 21 months in chemo alone, and the pathological complete response was achieved in up to 24% versus 2% in chemo alone. So there was a significant reduction in the significant achievement in pathological complete response, and this trial also showed significant reduction in distant recurrence, that is 10% versus 22% recurrence, and also in intracranial recurrence there is only 4% intracranial recurrence in CheckMate trial versus 13% recurrence with chemo alone. And if we see the NADIM trial, the NADIM trial stands for Neoadjuvant Immunotherapy Management Trial. It's also a phase 2 RCT in the same sets of patients with neoadjuvant being nivolumab plus chemotherapy and then surgery and then addition of the adjuvant nivolumab for the 6 months versus the neoadjuvant chemotherapy alone. And The trial has shown the landmark benefit with the addition of nivolumab in chemotherapy, that is PCR achieved in up to 37% versus 7%, and overall survival at 24 months was 85% versus 63%. And also the resectability rate was higher in immunotherapy arm. And thus this trial confirms the paradigm of perioperative immunotherapy, and additionally it also highlights the ctDNA as the crucial factor to define the escalation and de-escalation of the treatment, which we'll see in the coming slides. And another is the Keynote 671 trial for the perioperative pembrolizumab in resectable non-small cell lung cancer. It is a phase 3 trial in stage 2, 3A and 3B with end diseases, and the regimen uses neoadjuvant pembrolizumab plus chemotherapy followed by surgery, and then adjuvant pembrolizumab in up to 1 year. And the control arm being the chemotherapy alone without the addition of immunotherapy. The primary endpoint showed the overall survival was more than 52.4 months. However, the data has median overall survival was not reached, and 3 years overall survival was 71.3% in addition to immunotherapy versus 64% in chemo alone. And also the median event-free survival was 47.2 months in addition of immunotherapy versus 18.3 months in chemo alone. The pathological response, complete response achieved in addition to pembrolizumab was 18.1% versus 4%, and then major pathological response was seen in 30% versus 11%. But the toxicity associated with pembrolizumab was higher, that is more than higher grade, more than grade 3 adverse effects were associated with the pembrolizumab. So it was used, it is guided to be used in a selected patient, and with this trial the FDA approval was achieved for pembrolizumab in 2023, and establishing the perioperative pembrolizumab was as a standard of care. So there were various review evidence for the evolving role of neoadjuvant and perioperative immunotherapy in the resectable non-small cell lung cancer, as already been discussed. Over 20 different chemoimmunotherapy combinations have been studied, and the landmark phase 3 trial, they show the combination significantly improved pathological response, disease-free survival and overall survival, and these three are the major outcome that these trials have seen, and these data has already led to the global changes in clinical practice. So discussion of some other trials. There is a NeoStar trial published in 2023 with the addition of nivolumab in chemotherapy versus chemotherapy alone. The trial involved 4 arms with nivolumab plus ipilimumab, and nivolumab plus chemotherapy versus nivolumab, ipilimumab and chemotherapy, all given in the same patient. So in all of the 4 arms, the addition of nivolumab, ipilimumab and chemotherapy had the highest number of major pathological response, that is around 50%, and the pathological complete response was seen same in nivolumab plus CT and nivolumab plus chemotherapy plus ipilimumab, and the event-free survival was same in the nivolumab plus CT and addition of ipilimumab. So the addition of ipilimumab was not statistically significant, but addition of nivolumab in chemotherapy had major impact in pathological complete response and MPR. Another is NeoPre-IC from China, published in Shanghai Pulmo Journal, where the addition of sintilimab plus nab-paclitaxel plus carboplatin for 3 cycles was given before surgery and without any adjuvant treatment. And in this trial, 65% MPR, major pathological response, was achieved, and 40% complete pathological response was achieved in addition with sintilimab. So we have already discussed the NADIM 1 and 2 trial, and there is a NeoTORCH trial from the China again, where the addition of toripalimab with the platinum doublet chemotherapy for 3 cycles and then surgery, and then adjuvant to toripalimab was assessed, and the major pathological response was seen in up to 48% with pathological complete response in 24.8%. And even the median event-free survival was significantly better versus the chemotherapy alone, that is 24 months versus 15 months. So there are other trials such as AEGEAN trial using durvalumab and SAC trial using docetaxel plus durvalumab, and then NCT, newer NCT 03-16364 trial for adabrelumab, but these drugs are not FDA approved yet. And other trials also investigating neoadjuvant immunotherapy with the radiotherapy, but discussion of each of these is beyond the scope of my study today. So if we see the outcome of resectable locally advanced non-small cell cancer after neoadjuvant therapy in single institution, I have tried to take some literatures from USA alone, and this is from Miami, USA, from Miller School of Medicine, where they have done this study in 430 patients, and the R0 resection was achieved in 52%, 96% after the addition of immunotherapy. And the line diagram that we can see, the dot represents each and every patient, and we can see that most of the patients are either downstage or stable after the addition of immunotherapy, whereas 78% of overall downstaging was seen, and around 50% of pathological complete response was seen in this study. And there are other studies from the China as well, where the immunotherapy plus addition of anti-angiogenic therapy was studied. The anti-angiogenic therapy is commonly used in our center as well. The addition of bevacizumab is shown to be very synergistic for chemotherapy. But the conclusion is in this article is immunotherapy plus AA is safe and feasible, but it has not shown to be of any superiority over immunotherapy plus chemo alone. So the disease-free survival and overall survival are same, whereas there is a slightly increase in major pathological response only. If you see the Mayer curve, the disease-free survival, there is slight trend of improved disease-free survival in line with where the bevacizumab are used, but it is not statistically significant. And likewise, you can see various other articles, as I have shown in this slide, favoring the use of neoadjuvant chemoimmunotherapy for improved overall survival and pathological response of the patient. So the central dilemma now is neoadjuvant versus perioperative immunotherapy, and should we give the immunotherapy in neoadjuvant setting only, or should we continue it for the perioperative immunotherapy? So Checkmate 816 trial has shown that the neoadjuvant immunotherapy only has a PCR rate equivalent to those trials where the immunotherapy is added as adjuvant. So the lower cost, less demand on infusion centers, and it ensures the full systemic therapy, saying that the neoadjuvant chemoimmunotherapy alone and then surgery seems to be better choice than the perioperative immunotherapy. Although there is no head-to-head trial that exists, or cross-trial comparison are very unreliable, so the data are yet to be driven for the neoadjuvant versus perioperative immunotherapy. And the future direction is definitely the use of ctDNA for the need of better patient selection. The ctDNA can be used preoperatively to classify the high-risk patient. The higher number of ctDNA, meaning the more tumor cells are circulating inside the body. So after the post-op detecting molecular residual disease, that is detection of the ctDNA after the operation, these patients may benefit from the adjuvant therapy, sparing those who are completely cured. And post-treatment ctDNA, that is ctDNA is not cleared after the surgery, chemotherapy, or adjuvant therapy. This is the strong predictor for progression, negative predictor for progression-free survival and overall survival. So this can be used as a guide to treatment. And another questionable topic is immunotherapy in actionable oncogenic drivers such as in EGFR positive, KRAS positive. The current data does not support the use of immunotherapy in these patients. That is, targeted therapy is the way to go for the patient who are EGFR positive or KRAS positive, even in the neoadjuvant setting. The exception being early data suggests that BRAF mutation may respond well to the immunotherapy, and also the ROS mutation might respond well to the immunotherapy but requires the external validation as well as internal validation, and the data are still lacking. There are some novel therapies, that is bispecific antibodies, example ivonescimab, which is anti-PD-1 VEGF, showing impressive pathological complete rate in early trial, especially in the lung cancer. But the complete result is yet to be out. And definitely the future is adaptive. Trials are now using ctDNA and PCR status to guide therapy. That is, if the pathological complete response is not achieved, then we have to escalate the treatment. We have to add the antibody drug conjugate or add the chemotherapy. If the PCR is achieved, then we may have to abort the adjuvant therapy. Or if the ctDNA clearance is not achieved, we may have to escalate the treatment, or if it is cleared, we may have to consider the de-escalation of the treatment. These adaptive trial designs are definitely the future of onco trials. And take-home message being the lung cancer still remains the lethal despite advances in therapy, and chemoimmunotherapy neoadjuvant significantly improves the pathological response and survival outcome. It is safe, it is feasible, it does not delay surgery, but the multidisciplinary planning and selection of the patient is quintessential. Thank you.